Hello and welcome. I'm Ileana Piña. I'm professor of medicine at Thomas Jefferson University Hospital as the quality chief for the cardiovascular line. And we are here in Chicago at the American College of Cardiology meeting, which, by the way, is celebrating its 75th anniversary. And so today I am absolutely thrilled to have as my guest Dr. Eileen. She is director of transplant, heart transplant at the Cleveland Clinic at home base in Cleveland. And today we're going to talk about a trial called Fresh Up. We often don't do studies like this where we are determining fluid balance, nutritional balance, electrolytes, sodium, and yet they become very important in a patient's life because after they leave us, they still have to live in that real world. So Eileen, tell us about Fresh Up. I'm sure you've already looked at it.
It's a trial that is relatively small, although the largest
200
in this
some each patient
in
group,
each
right?
group, comparing actually fluid restriction, 1,500 milliliters a day, to liberal, just drinking what you want.
Yeah, do whatever you want.
And they're doing so in a cohort that doesn't have that much heart failure symptoms. So New York Heart Association Class 2, although they did include Class 3.
And was this HFrEF?
And no, it was all EF.
Okay.
The average, the mean EF was actually 40%. Half of them were actually HFrEF, but it included mid-range, it included HFpEF, a multi-center study that actually, although small, did try to replicate real-life experiences.
How many women?
About a third of the patients.
That's actually
were
not
women.
too bad.
Yeah, it's not
for
that bad.
What we usually see out there.
Yeah. And so they really wanted to know about quality of life. That was really the primary endpoint using the Kansas City questionnaire.
Did they have anything else to look at thirst specifically, how the patients felt about being thirsty?
Not as the primary endpoint.
Okay. So the primary endpoint was purely the KCCQ?
Yeah.
Okay.
And they followed them for 30 days.
Okay.
And so it was a short
That should be enough
study.
to see differences for
Yeah.
something like fluid.
Yeah.
Yeah.
And they didn't really find much differences. It seemed to be actually similar, except that there was a slight preference for actually liberalizing.
Yeah.
And
safe?
And it was safe.
That's a very important point.
Yeah.
Because I think our nursing pool actually on the floor thinks that if the patient have too many fluids, then they're going to require more diuretic and they're going to get puffy and they're going to get swollen.
They didn't include hospitalized patients, though.
So these are all outpatients.
So these were outpatients. They were stable. They had been diagnosed at least 6 months ago. Mm-hmm. They had relatively low NT-proBNP levels at
what
baseline.
Level?
The averages, the mean was about 400, maybe 500 per arm, so that they were relatively low. They were on really wonderful medical therapy.
Oh, really? Good background.
Yes. Okay. So 4 pillars was almost like 80%, if not higher. Mm-hmm. We didn't have the doses, things that you want to know. I liked the fact that they were questioning what we tell our patients. And we tell our patients this routinely with really little data. I think what we've learned so far is that finding that outpatient that is stable, that's been stable, that just comes in to check for a well visit, we would say. That's the patient that really could tolerate to liberalize the fluids.
So I try to take patients off their diuretics because of the jackknife renin-angiotensin increase. And not always recognized and certainly not always acted upon. And I think the guidelines do talk to us about some patients may not need that daily diuretic if you can get them to weigh themselves. Don't need anything fancy, just a scale at home. So I do the flexible diuretic regimen, 3 pounds in 3 days. Remind them about baseball, 3 pounds, 3 strikes, you're out. 3 pounds in 3 days and you take the diuretic. And I think that by avoiding the diuretic, the patients actually do better. As long as, physical exam remains stable. So I truly believe that when you're giving the patients instructions, and you know that the new patients know nothing, we spent at least an hour with a new patient, that you need to couple the diuretic regimen right along with the fluid. and what instructions are you giving them? And I know they ask our pharmacists all the time, well, do I drink water with the medicines? Do I have to take them on an empty stomach? So many sensible things. I think, Eileen, the other thing that we forget is that when patients are really, really sick with heart failure, especially early on, when they're not on a RAS inhibitor, angiotensin II is a powerful, powerful thirst driver. And these patients are so thirsty. And if you're trying to restrict them, I would think it's like torturing them. So I reach for the RAS inhibition first, because I know that that's where their symptoms may get better. Your thoughts?
Does everyone need a diuretic? I think that's incredibly important as a question. We do it for symptoms, and it actually does trigger the entire renin-angiotensin system as well as sympathetic, and so it does create its own cycle.
Exactly.
And so what you're doing is actually breaking that.
And you're starting it all over again when you do that.
I'm curious, do you still use the SGLT2 inhibitor if you're telling them that they don't need to use a diuretic? So,
oh, I love my SGLT2 inhibitors.
Yeah, because it makes you pee also.
It makes you pee,
So,
and as I say to the patients, this is trying to protect your kidney, which you've never really had a drug that we could clearly say that to them.
yeah.
You know, this is protective of the kidney. And it's easy to take once a day,
Yeah.
one dose.
And it doesn't make you have that urgency,
Exactly.
so that it makes people feel more normal, and they don't have to rush to the bathroom. So
Yeah.
there's
So I
doesn't
don't
restrict
take
their-
the SGLT2 away at all. But I do try to get them into the spirit of weighing themselves daily.
I use a totally different strategy.
Good, I want to hear.
So, and it's based on the fact that the very first few patients I ever met in real life clinic were 100 pounds up of fluid.
Oh God, yes.
So not patients from this Fresh Up. They were a different cohort. And I was just shocked by the amount of fluid that somebody could have. And of course I admitted them.
And how much can get held, especially
Yes,
in this
in the
third
belly.
space.
And
Third
so
space.
I asked the patients, you must have known you were gaining weight. And they said, but I didn't change on the scale. And the first person who said that, I thought they were lying. I was like,
Well, sure.
how could you not? I mean,
Sure.
you're 100 pounds more than you were. How could you not know? And the second one said the same thing. And then I started to think about that as a concept and realized that that is very plausible. When you actually develop shortness of breath and then you proceed to actually, let's say, have congestion in your liver, you lose your appetite. So you're not taking in calories.
That's true. That's absolutely true. They
And
don't
you're
need
gaining
as much.
water.
Yeah.
And it's balancing out.
Yep. Very much
And
so.
as you actually continue, you still can third space, as you said, a lot of fluid, and your appetite goes down and down and down if you are developing liver congestion. And then with that, actually, your mobility actually diminishes because you get short of breath.
Yeah, so they don't do much.
So they're losing muscle mass.
And they get deconditioned.
And then they continue to gain water. So is it plausible? It actually is. Those patients that claim that they gained 100 pounds but didn't change their weight, I asked, did they notice that their legs were swelling? And they said, yeah. I said, did you notice that you couldn't get your pants, on
And for
and
the
buckle
women,
them?
it's the bra.
Yeah.
They
And
can't
so they all said that they actually had signs and symptoms. So I usually ask them to actually start doing what you're doing, make an adjustment only if you have these symptoms.
Right.
I think that provides some control and hopefully reduces hospitalizations.
A lot of this is the long term and the short term.
Yeah.
The 3 pounds in 3 days is very short term. And what you're talking about is all more long term, the people that have gained that 100 pounds, but are not walking as much, are not doing as much.
Yeah.
And the eating is very important. Some of them are diabetic. We have a lot of
Yeah.
diabetics, and they get that early satiety syndrome. So they're not eating. And probably what they're eating is not very healthy for them. We need trials that kind of mimic life and mimic average life without, having to make it so difficult for the patients. You say, what do I want you to take? So you're talking about food, sodium, I still believe in sodium restriction, 2 gram. But again, making it simple for them. No lunch meats, no shaker, salt shaker at the table, and you can cook with a little bit of salt, which is in essence a 2 gram sodium diet.
Yeah.
So you have that, you have the fluid, then you have the meds, and you have the activity. Of all of those, which would you rather have them concentrate on? I want them to take their meds.
Because we know the natural history
And they
without
work.
medication.
That's right.
So that has already been declared and is still all over the internet saying that you're going to die within 5 years, which is not really based on our current regimen.
Not at all. Not at all.
So I too very much, feel strongly about medication. I actually really favor beta blockers. I think they really changed our entire.
Oh, totally. I hadn't seen reverse remodeling until we started putting the beta blockers on.
Thank you for saying that.
It is.
That is so important.
It is the reverse remodeler.
Yes. I mean, the RAS inhibition actually started to actually improve the dimension of the heart, the strength of the heart.
And how the patients feel.
And how the patients feel, and make a big difference. And especially, we use them the most when you even have more advanced heart failure. They're the one thing you can do to try to actually help with the remodeling. But the beta blocker was the only time we actually saw reverse.
Absolutely, we still see it. I think
reverse
some
the
of my
remodeling.
colleagues, though, are now so focused on, do I get the SGLT2 inhibitor on? Do I, the MRAs often fall off.
Yeah.
And we are not doing the up-titration of beta blockers that we used to do.
No.
I see a lot of people just at 50 of metoprolol, or even better, 3.125 of carvedilol.
So there,
The placebo
I think
dose.
that it is on us
It is on us.
to actually specify what do we need to do first. What is the most important? Bringing these concepts, what is really going to be the big bang? When you have low blood pressure, what do you need to titrate first? And to also reinforce that if you're really have no heart failure symptoms, we don't need to actually restrict your fluids. We can balance the taking of medication with some
common
quality.
sense. Some common sense.
Yeah.
Eileen, thank you for coming today. I hope the audience has enjoyed this sort of free fall conversation. We have these great drugs today that we did not have back then, that we couldn't offer the patients the longevity. So doing the right thing, precision medicine, every patient is a little bit different. This isn't cookbook.
And challenging dogma.
That's right.
I think that's important. You've always kind of taught me, always question.
Always
and
question.
never, assume that just because we do something, it's the right thing to do.
Yeah. Thank you for joining me today. This is Ileana Piña signing off.